So we'll be talking about arthroplasty and deformity limits of acute corrections. Again, it's an honor and privilege to be here. So the objectives of this talk to identify the cora in the setting of knee osteoarthritis. The reason I say that, as Dr. Rosberg said, that there are many patients, they come with joint arthritis, but you think that the deformity is coming from the joint, but it's actually you are missing long bone deformities. We'll touch base quickly on intraarticular corrections versus extraarticular correction. I think Dr. Tisworth did an amazing job in here. So what are the limits of acute intraarticular corrections during TKA? And then we'll talk about a study that we are doing to see the role of peroneal nerve release and decompression prior to severe valgus deformities at the time of TKA. So this is a patient who is severely disabled, came to the office with bilateral valgus deformities. His walking ability is not more than like one block, and you could see how he walks in this. So this is going to be like a case study. So the minute you see this patient, you want to examine him, you want to check the alignment test and the orientation test to see where the deformity is coming from. So it's obviously he does have a mild tibial deformity as well as the deformity is coming from the joint. You want to check the joint depression and you want to check the foot alignment. So in this patient, the patient had a plantar valgus deformity. So generally when you have a valgus deformity, the foot will compensate in a bit of varus, but you want to assess that clinically prior to the surgery to check if this patient needs foot orthotics, is the deformity flexible at the foot, does he need further intervention after the correction of the deformity. So that's an important to not to miss as well. Check the sagittal deformity, so the procurvatum and valgus will increase the risk of peroneal nerve palsy. Again, so these two angles are commonly used in the joint literatures, the anatomic tibiofemoral angle. So you see this patient has 24 degrees, 18 degrees mechanical angle. And again, there is a 6-degree difference between the anatomic and mechanical angle. And each of these angles has clinical implications. The anatomic angle will help you when you put your intramedullary guide, how much you need to do your distal cut. So if you measure both angles, you know it's 6 degrees. And the mechanical angle, why it's important, you could actually see if you take an intraarticular correction, which is it going to match 18 degree or are you going to miss more than that? Now here again, I'm not going to speak about that, Dr. Tisworth. This is an article I published a few years ago in the Academy Journal, again showing what limits you actually from doing acute intraarticular correction. As he said, ligament preservation, do you want to do it like, but I think the strategy he mentioned should be written in a book, and it's much better than what we wrote, honestly. You want to know if you want to manage bone defects, offset stem, and that's based on the preoperative planning. Now, these two papers, again, this is a paper that talks generally about preoperative planning in knee replacement. And this one, again, is more recently published, and I think they are both amazing papers. Let's go back to our patient. So anatomic valgus angle 24, mechanical valgus is 18, and then if you see the intraarticular correction here, actually, it's going to match. So I know that this patient, I could give him an intraarticular correction, one-stage surgery, without the need to correct any other deformity through the knee replacement. Now, what is the problem with that? This patient has 24 degrees of anatomical valgus, has 10 degrees of flexion contracture, so uncorrectable on examination, valgus. So you would think about the peroneal nerve palsy. Now, if you look at the literature, they report it as 0.3 to 1.5 to 10%, but I think there's a bias in the incidence of the peroneal nerve palsy because most literature will give the incidence of overall knee replacement, including varus knees, simple knees, not really the severe, like the patients with valgus deformity and flexion contracture, whether with or without. So the true incidence of the peroneal nerve palsy is, I think it's unknown. So now, what is the current management of peroneal nerve palsy? So the articles in the late 80s, the standard treatment, flex the knee, remove compressive dressings, give the patient AFO, do EMG probably at 0 week or like at the baseline, or you do it at 6 weeks. Some few new articles, including an article in the GBJS published from Rush Group, they recommended acute decompression, like immediately within 2 to 3 days. Then we asked the question, can we do it actually at the time of TKA if we suspect high incidence of peroneal nerve palsy? Now, meanwhile, in the deformity and the leg lengthening award, this technique has been well established, well recognized, and people will do actually peroneal nerve decompression for any valgus deformity correction. And based on this article, Dr. Paley actually, he recommends it peroneal nerve decompression if you have a deformity more than 5 degrees in an acute situation, and 15 degrees if you are doing a gradual correction. Now, maybe the circumstances are different in deformity patients, prior scarring, surgeries, but again, this is a well-established technique. So why don't we use it in joint replacement? So this study is a retrospective study. We looked at the patients. We have, it's ongoing recruitments. We have 10 knees and 9 patients. The inclusion criteria included anatomical valgus more than 15 degree with or without flexion contracture, and it's uncorrectable under examination and general anesthetics. So we looked at the demographics, peroneal nerve function post-op, pre and post-op range of motion, implants used, the operative time, and the minimum follow-up was 6 months for now. So now again, all patients, this is the same patient, I believe so, in this picture. On the left picture, you see how the valgus deformity. When you do the peroneal nerve decompression, you want to make sure that you have a good skin bridge. So make sure you have 8 centimeters between the 2 incisions. And the incision actually is not that big incision for the peroneal nerve. So you can see this one is like about 1.5 inches. And you could see the nerve here, and you do compress the nerve around the neck of the fibula. So what did we find? All patients, despite that we had deformities up to 26 degrees of valgus and flexion contractions actually up to 10 degrees. All patients had intact peroneal nerve function post-op. So this is in 10 knees. And one patient actually, in my group, one patient had a post-op hematoma and it was not at the peroneal nerve incision. It was at the total knee incision, and that patient had like I had to do like a little bit of excessive lateral release, and I think she did fantastic after 1 week of the post-op hematoma evacuation. She had no infection. You could see the operative time is a bit longer than the standard knee replacement, but when you do these cases with flexion contracture of 10 to 15 degrees, you have a valgus deformity of 25 degrees, you're going to spend more time. Most likely you're going to put some type of constrained knee. So in 8 knees, we use constrained knees, various valgus type implants, whether with a longer post, longer like a polyethylene that give you more constrained, whether with stem or without stems. In 2 knees, we use the standard PS knees. Again, I think the peroneal nerve decompression is an option, and surgeons should probably consider it in high-risk patients. And if you go back to see my patient, he's a Buffalo Bills fan. So you could see he's walking, and you can see this is how he was before and after the surgery. He's very happy. And thank you so much again for being here. And I would like honestly to thank my mentors, Dr. Rosberg and Fragman. I have learned a lot, and this picture on the left side is the graduation with my co-fellow, Rachel DeCona. She's amazing. Now she's in Kingston. This is a unique intraoperative picture because you rarely could see Dr. Fragman and Rosberg together in the OR. It happens like few times a year, but in this picture we were all the fellows and Dr. Fragman and Rosberg at the same time. Thank you so much.